I always start to scan the gallbladder in the midline like this and then move laterally until I can see the gallbladder. As you can see here, I've just swept across and I'm getting a nice view of the gallbladder. You don't always see this due to a bowel gas. This is just an image of the anatomy in more detail. The big problem is actually bowel gas, which you have to actually work around. With some people, this view won't work at all. Okay. Whenever I'm actually looking at the gallbladder as well, I always look at the liver, and I'm actually sweeping through the liver looking for any intrahepatic duct dilatation, which is very important. As you can see, I'm just sweeping through a long section. If somebody's very gassy, what you can also do is actually scan an intercostally like this, and what you're doing is you're just moving up and down the rib spaces, changing respiration. Again, what I'm doing here is actually looking for gross hepatic pathology and also any dilated intrahepatic ducts. What you can also do is compare the echogenicity of the liver to the echogenicity of the kidney, and the echogenicity of the kidney should be slightly less than that of the liver. As you can see here, I'm just moving up and down the rib spaces. The best view though is actually when you turn the patient into the right anterior oblique position, which we've done here. Okay, and then I'm just repeating the whole process again. So starting from the left lobe and then sweeping laterally. Okay, I'm just sweeping laterally now, and then I'm going to identify the gallbladder. I'm going to optimize the image here, changing the depth, focus, gain. You can also narrow the sector width as well, so you can see the aorta in a lot more detail. So what I'm doing here, I'm just looking at the gallbladder, looking at the gallbladder wall, looking for any stones, looking for any gallbladder wall thickening, looking for any fluid around. This is the fundus of the gallbladder, that's the neck, that's the portal vein. Okay, that's one of the renal arteries. So again, what I'm doing here, I'm just sweeping through in long section, making sure that I've seen everything, then rotating the probe, looking in a transverse, sweeping right the way through. I'm now narrowing the sector width down so we can see the gallbladder in more detail. This is improving the resolution. Now what we're going to do now is we're going to have a really good look all the way through, and then we'll have a look for the common bile duct. So to do this, what you do is you just rotate the probe towards the patient's right shoulder, and this opens up the gallbladder. This is the IVC, that's the portal vein, hepatic artery, and you can see the tiny CBD along the top. Normal diameter is 6 millimeters, but you can also allow 1 millimeter per decade of a life. And again, this is that image in more detail where you can see the IVC, porta, hepatic artery, and the CBD. What we'll do now is measure the CBD. Okay, so that's actually well within normal limits. As we said, 6 millimeters or 1 millimeter per decade of a life. What you also have to do is make sure is if it's possible, follow the CBD right the way to the head of the pancreas, as we are doing now. Okay, so there you go. There's the CBD right the way, all the way along from the porta to the head of the pancreas. And that is how I do my gallbladder scans. If necessary, we can also turn the patient decupitous, and we can also stand them up to actually see if there's any stones with the patient erect.